Good morning, everyone, and thanks to the committee for the invitation to speak. For the next 20 minutes, I'd like to talk about acquired left ventricular dysfunction. And we know that there are two distinct entities when we talk about left ventricular dysfunction. And the first is that of congenital and inherited forms of left ventricular dysfunction. And we know that these are as a result of congenital or hereditary conditions that are present from the time of birth. Is that transmitting okay? Yep. All right. As opposed to acquired, which is left ventricular dysfunction arising from exposures, and generally an innocent bystander, to environmental, hormonal, chemical, hemodynamic, emotional and physical stressors. So what makes a perfectly normal left ventricle turn into an abnormally functioning left ventricle? So what turns something that looks like this in the same heart turn into this? And so this is for the next 18 minutes or so, I'd like to go through some of the causes. I'd like to illustrate with some cases and get you thinking about some of the things that we can actually identify on echocardiography, and are they reversible or are they not? So in a fundamentally normal ventricle, we get LV dysfunction. It can be transient and reversible, and possibly not. It often presents acutely and may require intensive heart failure management therapy, including devices and circulatory support. And there was an excellent session this morning on ECMO and impeller and a lot of the new devices that we're using a lot more commonly to support these patients during an acute phase of their illness. Many causes have been described, but the mechanisms are often not always well understood. So, and sometimes the cause is just never known. So we know that the common causes of LV dysfunction, we're certainly not born with an ischemic or infarcted left ventricle, and this happens over time with exposure to environmental factors. We can get LV dysfunction from cardiac contusions, myocarditis and myopericarditis we see very commonly. Alcoholic cardiomyopathy can be seen, and also exposure to chemotherapeutic agents and also other psychoactive drugs that we monitor patients for routinely to look for acquired LV dysfunction. Now, what about these three things? These are largely toxins to the heart, but why doesn't everyone get them? And we think that possibly there is a role for a second hit theory, and possibly there is an underlying component of pre-existing cardiomyopathy that these agents really bring out in these folks, because clearly not everybody gets it. And also arrhythmias. So let's have a look at some cases to illustrate some of the more reversible causes. So this is the first case. This is a 69-year-old lady. She got chest pain while walking uphill, 8 on 10 central chest radiating to the left arm, associated with nausea and presyncope. And her only background cardiac history was that of hypertension, which was very well controlled on avapro. She was pale and diaphoretic, hypotensive, in sinus rhythm though, and normal saturations and an ejection systolic murmur at the base. Her blood test showed normal electrolytes, liver function, full blood count, but as you can see, the troponin was dramatically elevated, and the CK surprisingly not quite as elevated and probably disproportionate to the troponin. We can see that she had some ECG changes, predominantly in the anteroseptal leads with ST elevation and T-wave inversion, and as you can also detect there, a prolongation of the QT interval. So you should be starting to think of the diagnosis right away. She was seen in the emergency room, no improvement in the blood pressure with 500 mils of normal saline, and she was prepared for going straight to the lab to look for an occluded coronary artery. So she was given heparin and ticagrelor and sent to the lab. So this is her coronary angiogram, and for those non-interventionists in the room or non-cath lab people, this is a perfectly normal left-sided coronary artery circulation, no occlusive lesions. And similarly on the right coronary artery, lovely big normal right coronary artery there. So what's going on? Let's have a look at the LV-gram. So you can see here that the apex is completely dilated and dyskinetic, and there is hypercontractility of the base. Can everyone see that? Very good. And when they did the intracardiac pressures, you can see that the pressure in the left ventricle is 140 on 40 millimetres of mercury, and the pullback gradient, so when the catheter is pulled back across the aortic valve, the aortic pressure was 70 on 40. So there was a pullback gradient of 70 millimetres of mercury. So you should be starting to put it together. If you have hypercontractile function of the basal segments of the heart, and then you've got a pullback gradient of 70, then obviously there's a large degree of left ventricular outflow tract obstruction. So as all acute cases, they go to the cath lab first and then get their echo. And this is what we see on echocardiography. So you can see that there is almost complete occlusion of the left ventricular outflow tract. The segments of the mid-wall are not contracting at all. And the anterior leaflet of the mitral valve is getting pulled into the outflow tract, causing obstruction. And for the clever people in the audience, if you have a look at the aortic valve, you can see that it closes prematurely. Let's give you a moment to look at that. We put the colour on and you can see the accelerated flow throughout the outflow tract and of course the resultant mitral regurgitation that's occurring. That's just to put them side by side for your reference. And if we look at the basal segments on echocardiography, on the left-hand side of the screen, you can see that they're hypercontractile and hyperdynamic, whereas the mid to apical segments on the right-hand side of the screen are barely contracting at all. They've lost that longitudinal function, and you can simply see just a remnant of circumferential twisting that's left behind. This is the apical four-chamber, and again, you can see the contractile components of the base, and really nothing going on from the mid to apical areas. Similarly in the two-chamber and in the three-chamber. And that sucking in of the mitral, the anterior leaflet of the mitral valve, causing left ventricular outflow tract obstruction and hence the hypotension. Now, to go back to the strain map, this is very typical of a condition called Takotsubo Cardiomyopathy. And when you get this apical ballooning syndrome, this is the kind of strain plot that you see. You get hypercontractile segments in the base of the heart and the mid and apical segments, as you can see here. Anything that's not negative is positive and dyskinetic, and so these ones are actually going out when the rest is going in. This was the gradient through the outflow tract, approximately 100 millimetres of mercury, so by the time she'd had her cath, the outflow tract obstruction was worse. And for the old-fashioned of you in the audience who like M mode, you can see the traditional sign of the anterior motion of the mitral valve into the outflow tract there. So what was her clinical course? The next day, troponin 722 from 484, so continuing to increase, but her blood pressure had improved. She was on Pressors, this lady. You can't give her Lasix because her ventricle will just collapse and the outflow tract will get worse. So she needs Pressors initially, and then you can actually start to manage the fluids and the rate control. And she was started on metoprolol inhibitor. Her ECG continued to evolve and still a prolonged QT syndrome there, which is transient. So 4 days later, you can see what's happened to the left ventricle. It's starting to regain its function. This is a very transient condition that this lady has. And when you serially look at these folks, usually within 3 to 5 days, the left ventricle is almost back to normal. Even in the apical views, you can see that there has been almost complete recovery aside from some distal apical dysfunction. Most of that myocardium is actually back to normal, so very transient. So you get someone who's admitted on a Saturday, doesn't get their echo till Monday or Tuesday, you might actually miss the diagnosis. And you can see that there's still a little bit of outflow tract acceleration and only minimal mitral regurgitation now. This is 5 months later, and look how beautiful that looks. So this is a reversible cause of acquired left ventricular dysfunction. So what is Takotsubo cardiomyopathy? It's a stress-induced cardiomyopathy, can be triggered by emotional, physical stress, and in about 30% of cases there's no obvious trigger. It's poorly understood the mechanisms, although it's thought to relate to catecholamine excess, and the distribution of the wall motion abnormality is likely to be related to the density of the beta receptors in the myocardium. The clinical features are similar and almost indistinguishable from acute coronary syndrome. Its definition is defined by the absence of obstructive coronary disease, non-regional distribution of wall motion abnormalities, and this appearance on the LV-gram of a Takotsubo Japanese octopus pot. And it was also characterised by QT prolongation, which can be a cause of excessive mortality The apical variant is the most common, but there have been others described. And there has been a registry of nearly 2,000 patients, and it was interesting to see what their triggers were. Physically, 36%, emotional triggers in 28%, and in the remaining 30% or so, there was no specific trigger. Importantly, 90% of the cases occur in women, usually postmenopausally, but not always. And there is some research going on in Europe about looking at hormone replacement therapy and whether estrogens actually play a role in preventing or treating or reducing recurrence rates, but that's still in the pipeline. The rate of neurological or psychiatric disorders are more common compared with acute coronary syndrome. And the mean presentation ejection fraction is usually lower than compared with acute coronary syndrome. Troponin levels are similar, and they increase to approximately 1.8 compared with acute coronary syndrome, which is approximately 6 times, and the BNP is usually always elevated. Most patients will have ST elevation, and very few will have ST depression compared with ACS. And in this series, the in-hospital rates of death were similar to those in ACS. So we think of it as a sort of benign condition which recovers and goes away, but it actually does have ongoing mortality. In hospital, the predictors of worse in-hospital complications were physical triggers, acute neurologic disorders, higher troponin levels and low EF on admission, and long-term follow-up. There was a significant worsening of mortality over time, mainly major adverse cardiac events, and out to 10 years. The treatment options are the usual neurohormonal blocking agents and also anticoagulation, because in the acute phase, the apex can develop apical thrombus, and this can obviously cause a life-threatening event. The recurrence rate is significant. 10% over 10 years, patients can have recurrence, and beta blockers in this series showed no absolute survival benefit at 1 year. So it's something we should think about. We should look for recovery of these folks, watch them over time, and actually make them aware that it can recur. And I guess treatment of this condition is something that's still evolving. So on to the second case. This is an 83-year-old lady of mine, very highly functioning, runs the CWA in Queensland and also runs a homeless shelter. She presented with 2 weeks history of shortness of breath, orthopnea, P&D edema, and new atrial fibrillation was noted with a rapid ventricular rate of 120 beats per minute and no cardiac history to speak of at all. And this is her echocardiogram at presentation. You can see in all views, she actually has a global reduction in left and right ventricular dysfunction. She also has biatrial dilatation and some pericardial fluid. She was about 6 or 7 litres overloaded when I first saw her in the clinic. She also had torrential MR and probably grade 3 to 4 on 4 TR as well. Now, we'll look at her strain plot, and you can see that she's actually got very, very poor myocardial strain. So she's not generating much in the way of output or myocardial contraction, and as you can see, the anterolateral wall is almost dyskinetic. So she was diuresed, started on antiarrhythmic therapy, anticoagulation to facilitate cardioversion, and she went for a TOE-guided cardioversion. You can see even within 2 weeks before she gets to her transesophageal echo, the left and right ventricular function have further deteriorated. This is a very common thing we see in patients with new and symptomatic atrial fibrillation. When we actually do a biplane it's almost completely back to normal. And this is in an 83-year-old. So we often see this in symptomatic AF and flutter, and we should always attempt to try and revert the rhythm to try and improve the left ventricular function. So lastly, how am I going? I've got a few minutes? 3 minutes. Oh, I can do this. Okay. So the third case, Taki? Yeah. Okay, Taki speaking. Good. 37-year-old female who had a cardiac arrest during the birth of her second child, and this is her transthoracic echocardiogram. Now, the image quality is not that great, and you might think that that's a clipping artefact, but her heart rate was actually 200 beats per minute. So this is not a clipping artefact, and you can see she has global left and right ventricular dysfunction on presentation. Went straight to transesophageal echo after being intubated, and again, this is not a clipping artefact. She seriously has an ejection fraction that you can probably count on one, maybe two hands. In all of the transesophageal views, 4-chamber, 2-chamber and 3-chamber, again, you get the same impression, and particularly in the 3-chamber, you can appreciate the right ventricular dysfunction. So she went on to have a BIVAD implant, and I think there's a session on that later this afternoon, with a view to transplant or recovery. And she went on and had the BIVAD put in for both the left and right ventricle to support the circulation. Within a couple of weeks, she actually had complete left ventricular function recovery, but not complete right ventricular function recovery. So the devices were kept in place, but unfortunately she developed some complications and went on to need thrombolysis and continued to get thrombosis of the cannulae. And it was eventually decided, because her left ventricular function, here seen on the contrast imaging, that her left ventricular function had actually regained normal function, the RV still mildly to moderately reduced, and it was elected to remove both of the left and the right ventricular assist device. And she's actually gone home and is doing very, very well. So peripartum cardiomyopathy, the mechanisms are poorly understood, thought to have some underpinnings related to vascular dysfunction in response to surges in maternal hormones at delivery. And there is a possibility there is a genetic predisposition. The definition is not precisely defined, but ejection fraction is less than 45% at diagnosis is the American Heart Association classification, and it occurs in late pregnancy, usually the last week of pregnancy into 5 months postpartum, and the incidence is about 0.1 to 0.3%. Increased risk in multi-gestational, so twin and triplet pregnancies, the mother over 40 years, and some racial factors increased in Black American ladies. So the two hormones that are thought to be at play here at late gestation and early delivery is the surge in the prolactin and also tyrosine kinase hormone, which some ladies are particularly sensitive to, and it's thought that blocking some of these agents, progress is underway and research is being done at actually looking at the use of bromocriptine in arresting prolactin production in these ladies to help with their recovery. We know that peripartum cardiomyopathy usually recovers, but not always. You can require mechanical support for these women, and approximately 90% of these ladies will recover an ejection fraction to greater than 50%, and approximately 13% will have persistent LV dysfunction. And the risk of recurrence is increased in those women who go on to have a subsequent pregnancy if the EF is incompletely recovered at the 6 to 12 month mark, and mostly 6 months you're done. So you very rarely see improvement at 12 months if they haven't had improvement to 6 months. So the not so common acquired causes of LV dysfunction, we've gone through Takotsubo, peripartum, the atrial arrhythmias, but there's also some other special reversible ones such as amyloid, which Greg's going to talk about shortly, sarcoidosis and pacemaker-induced cardiomyopathies. And just keep in mind that these things are acquired, they're often reversible, and in some patients may actually reveal an underlying cardiomyopathy that you need to watch down the track in the future. They might get recovery initially, but then they can actually go on to develop LV dysfunction. So with that, I'll conclude. Thank you very much.